is Dr. Patty Best. On the left is Dr. Patty Best, and then Dr. Marisha Tweet. And if you have ever done a search for any of our literature, Dr. Tweet is often the first author. I will bring her in, but if I'm the guru, she's the guru too. In my opinion, Dr. Tweet and I started studying SCAD when she was still an internal medicine resident, and she has continued it as now a mid-career faculty member with NIH funding to study SCAD over 5 years. Oh, I'll go back just because up here you see the guy pointing. That's Dr. Rajiv Gulati. You'll also see his name. He is the one we really depend upon for his angiographic expertise. So this is just a graphic on the back of one of our skedaddle shirts. But I want to level set. Some of you are probably experts on SCAD because you've had it or you've done a lot of research yourself. But I'm going to start with taking nothing for granted tonight. So spontaneous coronary artery dissection, it is mostly women, more than 90%. The average age, kind of 40s to 50s, but we've seen teenagers and individuals who are over 70. So there's kind of a bell curve that you'll see. It is the #1 cause of heart attack in women less than 50 years. It is a common and probably #1 cause of heart attack in patients who are pregnant or recently given birth. And there are minimal what we would call typical risk factors for coronary disease. Often our athletes are normal cholesterol, non-smoker. But we used to say, and you might still hear, or you could read something I said a long time ago, that there was an absence of risk factors. And actually, hypertension is not uncommon. It is probably as common as it is in the general population, which becomes important, I think, in terms of prevention. And rarely there is familial SCAD, although we've done enough work that we know that there's no specific SCAD gene. We know that there are at least 17 gene mutations. We'll talk a little bit more, or that are more common in patients with SCAD than in the general population, but they're still pretty common in the general population. And that is one of our challenges in trying to predict it. So again, what is SCAD? So the normal artery on the left, and then you see, so here is SCAD. This is called an intramural hematoma, and that means there's a split between the layers, but not a through and through tear. The intimal tear is here where you've got a flap. Now, I want you to look at this one and the atherosclerosis. And if you can think of an angiogram, you can see how if you were only seeing the outline, you might not know the difference between these two. And one of the reasons, and we'll talk about it a little bit later, because some people have said, is it more common or are we just diagnosing it more? This was the only angiographic appearance that was considered correct. This is what I learned on how to diagnose a SCAD until about 2012, 2013. This, we now know, this intimal tear only makes up about 30%. The vast majority are in intramural hematoma. So when people saw that, when cardiologists saw that on an angiogram, they were calling it normal, spasm, coronary artery disease, or plaque. And so there were a lot of people who were getting different diagnoses back then, but it's not atherosclerosis. All right, so this is a coronary angiogram. This is the SCAD affected angiogram. I don't expect you to be able to tell that, but I think what you can see is it's a little smaller. Maybe I can stop it and move it a little bit. It kind of inappropriately narrows down here. But this was one that was kind of tough to diagnose. So this is called an optical coherence tomography catheter. That circle right there is actually the catheter. The black part is the blood. And what you can see, and I'm going to stop this here. I can bring it back. All right. You see, this is the normal artery. Do you see this and this? That's the split between the artery. So this type of technique can be very helpful. We also use intravascular ultrasound. Now, in experienced hands, if you see a SCAD, we don't do this automatically. So that's one question. Well, why didn't my doctor do this? This is actually done during the angiogram. And it's called intravascular imaging or ultrasound. But it can be very helpful when we can't tell for sure. So getting back to Pauline's experience, prior to the early 2010s, SCAD was said it's rare, extremely rare. It was sort of individual case reports in the medical literature, and it was reported in those scary things that Pauline talked about as a 30 to 80% fatality rate. In fact, there are studies that are it was reportable. Somebody survived. I'm going to write a paper about it. And so Google searches were very scary. And it was literally a sentence. I used to say it was a paragraph in my cardiology textbook, and then I was giving a big talk, and it literally was a sentence. SCAD was mentioned twice in my cardiology textbook, once here and once in a list of about 200 causes of heart attack. This is another, just so you can see where we have come. If you look at the publications, this is from PubMed, this is indexed publications about SCAD. From 1976 to 2011, there were 550 publications, but through 2025, there's been 3 times that much in that 15 years. So there's I think you should all there's a great deal of interest in this condition. This was our first. I will tell you, I thought I would share a little bit about research in addition to SCAD, because that is what I do. When people say we made a poster, they think, well, that's what my kid did to say vote for secretary of the class in junior high school. But in fact, posters are a way at scientific meetings that scientists present their initial data. And this was our very first poster about SCAD, where we really just had 12 patients, and it was, can we actually do a study? Can we get enough SCAD patients to learn anything about it? But posters are before the publication, and you get people walking around at meetings asking you questions and getting interested. So what's changed from back then? Well, one, just what we have here, patient-initiated research and advocacy, scientific and clinical collaborations. While SCAD, we used to call it rare, it's still uncommon, and it's still hard to research, because you need a lot to get meaningful data. You need a lot of people who have the condition. So that means even a Mayo Clinic is going to be collaborating with other institutions. And we've collaborated with folks in France and in England and Australia and across the US. So there are now larger case series and registries. And with each of these, what we thought we knew, then a hypothesis is when you analyze your data, all of a sudden there's a new question, and then we try to test it. But I think that our goal for us is managing SCAD, caring for survivors, and providing some evidence so we can address the so many still unanswered questions. This was a big deal. This is back from 2018, but the American Heart Association, when they publish a scientific statement or a guideline that makes that condition is sort of arrived. A scientific statement is one that doesn't have as much evidence behind it as a guideline, but you can see in red three of the many authors who were a great working group were from Mayo Clinic. So I told you I'd tell you a little bit about, is SCAD happening more often, or were we missing it? Now, my contention, and I had this sort of back and forth with Dr. Galati, my close colleague and research collaborator, he thought it was getting more common. That was his observation. I said, I don't think so. I think we've been missing it. So 2 studies were published just within the past couple of months. The first one looked at women who were under age 55 who had acute coronary syndrome. That's what ACS is, or a heart attack. And 23% of them had SCAD, but 41% were initially called something else, misclassified. So this group went back and looked at all the angiograms again, knowing what we know now. And that's a pretty modern group, 2012 to 2024. That next one is one for which Dr. Galati, remember we had he was senior author on this. I'm a middle author. And he and Dr. Raphael looked at all of the heart attacks and the angiograms from less than age 65. And again, 11% had SCAD after this much larger group. 60% were misclassified. Now, the misclassification got much better after 2012 when data was published. So I think what we believe is that there were many people who were probably misdiagnosed. The rise in cases is because we're getting better at diagnosing it. So the symptoms of SCAD are heart attack symptoms. I think that's important because I've given talks on this and I've had a follow-up question. Well, I've been having shortness of breath for 8 years. Maybe I have SCAD. And I think it's important that this is an event, typically. STEMI, ST elevation myocardial infarction, is the most serious type of heart attack, and about 40% present with that. Ventricular fibrillation or some type of arrhythmia is common and affecting more than one vessel. So SCAD, it's dissecting in 2 separate vessels, happens in about a quarter of individuals. About 20% of individuals say they had a trigger, but often either severe emotional or physical stress. That means about 4 in 5 do not. They're sitting on the couch enjoying themselves. So I think don't overlook, overthink what might have been happening beforehand. The other things we've learned is traditional heart attack treatments are not always appropriate. And that's because they're more difficult to place, the complication rate is greater, and SCAD arteries often heal on their own. And if we can avoid putting a stent in, then that's probably better for many patients. A lot of patients have chest pain, and we'll talk about that. But as I said, the majority, if left alone, now we can't always leave them alone. And I think that's an important point. Even though we'd like to, if a patient is unstable, if their blood pressure is low, they're having ongoing chest pain, we need to sort of bite the bullet and go ahead and put a stent or do a bypass operation. One thing I like to, this is an important slide that I tell to my physicians. It was a nice review, and I'll just tell our strategy has been, even though we're mainly cardiologists, we're a multidisciplinary team in our research, and we need lots of people to know about SCAD. And so we're publishing in literature in emergency medicine, in OB-GYN, in internal medicine, and general internal medicine. But this was a study where we looked at the symptoms of patients who had SCAD, and so almost 1,200 patients, and over 95% had chest pain. So don't let anybody say this is atypical. Now, there may have been many other symptoms, but most of the patients in terms of who I have seen in clinic have had symptoms that were very similar to heart attacks. All of those other symptoms there are common symptoms of heart attacks, not atypical. I think the other thing is the troponin was normal, the first one in 20%. That's really important because at least in the US, I don't know about Ireland, there's a big move to try to expedite care and decision-making in patients who present to the emergency department with chest pain. And there are some protocols that would say, okay, if they're young, they don't have cholesterol, 1 troponin might be enough. And we would advocate and say if the symptoms are right, 1 troponin is not. Troponins, the reason is they tend to rise. That is an enzyme that leaks from the heart muscle when it's injured. And so we advocate for those who have the right story, let's keep them there and get a 2 or even a 6-hour troponin. Now, nobody wants to hear about possibly having another SCAD. And when I first started studying this, there was a lot of people who said, well, this is just a lightning strike. Once it's happened, it'll never happen again. We know better or worse now. There is about a 2 to 3% rate of recurrence per year. It can happen very early or out 20 years. So unlike a breast cancer where we say, oh, if you're at X number of years, you all check out, you haven't had recurrent cancer, you're home free. That doesn't appear to be the case for SCAD. And in fact, probably there are some people who are higher risk and some people who are lower risk. And currently the research does not allow us to really risk stratify to be able to point those people out. Excuse me. It often occurs in a different artery. And rarely we have 3 to 4 or more recurrences. And importantly, putting a stent in does not prevent a recurrence because remember, it happens in a different artery. So let's talk about some of the therapies that we have some evidence for. I would just say there really isn't anything that's specific to SCAD. We've talked about maybe not putting a stent in. Beta blockers. The most common beta blocker in the US is metoprolol, and I don't think that's the same in Ireland, but maybe it is. But the reason they are often used after SCAD is because they were associated with lower recurrence rates in a single study. Now, this single study was done by a good group, Dr. Jackie Saw in Vancouver, but even they were unable to replicate the benefits of beta blockers in a prospective trial, and we were not able to either. However, I generally do recommend a beta blocker for at least a year if patients are tolerating it well, because there's some reason to think it may benefit patients. It stabilizes heart rhythm, it decreases the work of the heart, and lowers blood pressure. And there's currently in Europe a prospective trial that is looking at both aspirin and beta blockers to see if that is something that is beneficial. We definitely, though, whether it's with a beta blocker or not, treat elevated blood pressure. Our goal is to be normal, less than 120/80. Statins are not routine. They are routine for an atherosclerotic heart attack, but they don't make any difference. The reason we use them for a regular heart attack is because they prevent recurrence. There's no evidence that statins prevent recurrence of SCAD. And so unless somebody has very high cholesterol and would otherwise qualify, we don't do that. Any other treatment is not SCAD specific. You know, if somebody gets a stent, they need to be on dual antiplatelet therapy. If they have a low ejection fraction or reduced heart pumping function, they need medication for that. If they have chest pain or angina, we will treat that if they have depression. But again, those are not SCAD specific. Those would be for heart attacks. Now, we do recommend if patients are on hormones that they would stop it, most oral contraceptives and hormone therapy. And if they are on triptan medications for migraine headaches, we recommend they stop that after a heart attack. And that would be after a heart attack of any kind, because triptan medications cause vasoconstriction of the arteries and have known cardiac side effects. So we've talked about merely kind of not knowing exactly what causes SCAD, but we do know some things that may be causal and definitely are associated. So one of the things that we noticed in our first 2012 paper is if you look on the left here, when somebody's going through doing an angiogram, one of our angiographers, whether they're going through the leg, and this is the femoral artery, that's a hip socket, or through the arm, they will inject dye, a little dye, to make sure they're in the right place. Sometimes they take a picture of it. So in our first group of 87 patients, we had 12 where the picture of the femoral artery was taken. And among those 12, 6 of them looked like this with fibromuscular dysplasia. So 50% of those. And we were starting to see that in clinic. And subsequently, others have done that, and with rates of fibromuscular dysplasia or other abnormalities up to 60 to 80%. So one of the things that has evolved over the past few years is that the majority of patients who have a SCAD, if we go looking, doing a CT angiogram or MR angiogram, in over 50% we'll find either fibromuscular dysplasia or another dissection or an aneurysm or some other abnormality in the other arteries. So it's important that that we don't call this ruling out fibromuscular dysplasia or FMD, because we really can't do that. I used to tell patients 5 or 6 years ago, I said, good news, your scan's negative. We're ruling it out. Well, we've now had some people that had very normal scans, but they liked that leg artery. They had some in their arm artery, but nowhere else. So we don't look for that. So thinking about this scan as sort of a baseline to make sure that there's not something else that we need to treat, like a brain aneurysm, or to follow up. That's the reason for this. And currently, we are recommending patients have a repeat in about 5 years, even if it's normal. Let's talk a little bit about pregnancy associated. That was some of the SCADs that were more likely to be diagnosed, because this association has been known for a long time. But if the SCAD occurs around pregnancy, it tends to be more severe. It's more likely to be a STEMI. It's more likely to occur in multiple vessels. It's more likely to result in decreased heart pumping function. And the vast majority happen in the first 4 weeks, and actually half of those in the first week. So that's kind of the reason we recommend after a SCAD that we avoid pregnancy. We recommend using an effective non-hormonal contraception, so not oral contraceptive pills. The levonorgestrel IUD is particularly useful because it really doesn't elute much in the way of hormones, just locally, and it actually decreases the rate of menstrual bleeding. For premenopausal women, that can be important because if you've been put on anticoagulants or antiplatelet agents, many women will have pretty heavy periods, and a lot of cardiologists aren't very aware of that. But obviously, partner vasectomy and others. Now, this recommendation, as you might imagine, lands very differently if you're a 42-year-old woman with 3 children and your family was complete compared to the 20-year-old college student who doesn't have a boyfriend. And I think that that's a really important, and since we're continuing to look at, the safest thing would be not to have a pregnancy, but we know that some people will get pregnant, and some people just find that that's something that's really important. The little bit of data we have would say that most women will tolerate pregnancy and lactation after SCAD without a SCAD recurrence, but kind of ballpark about 10% will have a recurrent SCAD if they have a pregnancy. Now, some people will look at that data sitting there with their partner and they will say, absolutely not. That risk is way, way too high. I would never try to, I'm good. And others would look at that and say, 9 out of 10 do fine. I want a pregnancy so badly. And so while we continue to discourage, we do have a shared decision-making conversation, and I want to make sure that the partner's there. And we have to review medications and ejection fraction. And if pregnancy occurs, then a cardio OB team is a must, and that includes pediatricians, anesthesiology, and cardiology. I want to shift gears. We talked a lot about women, pregnancy and everything, but SCAD does occur in men, less common. About 10%, they have similar presentation and cardiac risk, so hypertension and the like. They are more likely to have an exercise trigger and less likely to have an emotional trigger compared to women. They're less likely to have associated fibromuscular dysplasia or migraines. And after SCAD, compared to women, they're less likely to return to the emergency department with recurrent chest pain. Their outcomes are very similar. But I think remembering that if we think we don't know enough about SCAD, we know even less about SCAD in women and men, And so I think it's really important that we continue to enroll men in the research. This doesn't come off as solely women's disease. Just like men get breast cancer and men get osteoporosis, we need to make sure we include them because learning about SCAD in men may very much help women as well. Importantly, cardiac rehab, it's safe, it's effective, it's beneficial, and it's very undersubscribed. I don't know how it is in Ireland, but in our country, cardiac rehabilitation in general, particularly for women, is under-recommended. And for SCAD patients, often because they look healthy and whoever is recommending it. This was data that just came out, and I've used this slide actually for physicians because they looked at France, a little closer to you than me, in 51 centers caring for SCAD. Only 27% of those patients, and 50% did interval training. Only 51%, half of those 51, even referred a single person to cardiac rehab after SCAD. So the reasons that were cited for no cardiac rehab: wait times, the patient refused, or the team thought they shouldn't do it. But the vast majority is the referring physician forgot or thought it was irrelevant. And those who did go to rehab improved. And of the women and men who discontinued or refused, they said it was too easy. So cardiac rehab for women after SCAD, cardiac rehab needs to be individualized. So we have a number of performance measures. I think this is really important that we know that SCAD is now being specifically mentioned in terms of prevention and quality measures. And this one that was published earlier this year if it is after SCAD, somebody's going to be checking the boxes to make sure SCAD patients are referred to cardiac rehab. In the scientific statement I showed earlier, the European Society of Cardiology all recommend cardiac rehab for all with SCAD. I think it's important because many, this I know from patients who have shared with me at cardiac rehab elsewhere, are given heart rate restrictions or blood pressure restrictions or specific arbitrary weightlifting restrictions. None of those are appropriate. Those should be individualized. There's a short list of activities we recommend avoiding, and we'll talk more detailed about that. At least in the US, this is kind of, we have a lot of rehab providers and they sort of throw up their hands when they see a young patient who had a SCAD. I don't know how to take care of a patient with SCAD. I don't know what to do with them. And so Dr. Tweet, who I told you I'd mention again, she actually, every 2 years, they update their recommendations. So this is a screenshot from their book, No Excuses. She goes on and writes a whole section about how to evaluate and treat patients with rehab. Hopefully this will make a difference. So physical activity first, within the first 1 to 2 weeks, we recommend SCAD, SCAD patients get into cardiac rehab. We talk about avoiding competitive endurance. I talk about them exercising to exhaustion, high intensity, prolonged activities like training for a marathon or a half marathon, especially in extreme temperatures. And we get both here in Minnesota. We get 95 degrees Fahrenheit with high humidity in the summer, and then it's well below 0 Fahrenheit in the winter. And that's not the time to go out for a vigorous exercise session, maybe just taking a walk. We encourage strength training. Early on, women with SCAD were told, oh, never lift anything over 10 pounds. I will tell you, one, that is a guaranteed osteoporosis, weak, frail old lady situation. It also, what if you just had a baby and that baby hits 10 pounds? That was very arbitrary. So we want women to be strong, and we want to do them lifting with good lifting technique, which means breathing out. But we want them to avoid pushing, pulling, or lifting anything that requires them to hold their breath and bear down for a prolonged period of time. That's called a Valsalva. And if you have to do like that, then it's probably too much. Maybe you can work up to that. So here's a we published in the European Heart Journal in 2021, and this graphic has been very helpful for both. We sometimes print it out and give it to patients because it's sort of a green, yellow, red light. So yes, green, do moderate exercise, do weight training. With caution, endurance aerobic training, muscle building, yoga poses, but avoiding those things that we already talking about. The one additional thing I would say is we also tell patients to avoid torsional neck movements. And you say, what does that have to do with my heart? So a chiropractor doing a neck manipulation. Well, there have been case reports of patients having neck artery dissections after chiropractic neck manipulations. And so, if you go for a low back or a massage to the chiropractor, but not the whole uncontrolled head movement. And here's the front page of that article. So many of you probably experienced chest pain after SCAD. It's common, it's scary. There's many causes, some of which are not cardiac, but if you just had a heart attack and you're feeling somewhere up here, you're afraid. The other thing that's important to know, or for cardiologists to know, is some people will have more symptoms in the couple of days leading up to their menstrual cycle. That is not well known by cardiologists. It is not new and it's not unique to SCAD, but we did publish a small case series just so patients could say, when their cardiologist said, I've never heard of that, to say, well, other people have. We can evaluate stress tests, chest pain with stress tests, with a coronary CT angiogram. Sometimes the sort of poor man stress test is, I'll try nitroglycerin. So if it sounds like it might be cardiac, but it's not exertional, and the patient's having random chest discomfort, taking a sublingual nitroglycerin, if it is coronary vasospasm, which is sometimes present, it will go away. It's very powerful. It may give somebody a headache, but at least we know that maybe that's something we can build upon by giving somebody vasodilators. But if chest pain keeps going, or if the stress test is abnormal, sometimes we'll have to repeat a coronary angiogram. We talked about uterine bleeding, that can be an issue, fibromuscular dysplasia, migraine management. Fortunately, in the past 5 years, um, the reason migraine management is important is because about 30% of patients who have a SCAD have migraine headaches. And if you take away their triptans, which has often been one of their really effective mechanisms for controlling the headaches, we were kind of left with not much until about 5 years ago. And now there's about 6 or 7 new migraine treatments that are pretty cardiac safe, that we can offer them. And so I refer them to a headache neurologist. We can't give a talk about SCAD without talking about the psychosocial burden and the losses that individuals feel, whether it's anxiety, PTSD, or depression, or the fact that even if you didn't plan to have another baby, the fact that I've been told now I can't or shouldn't, that is a loss of just the option. And I think that's why cardiac rehab is so incredibly important. So to start summarizing what we need to do: blood pressure control, less than 120/80, avoiding triptans, providing psychological support for patients and family, and considering a genetics consultation. Remember, we said there is no SCAD gene, but there are some genes that are associated with aneurysms and dissections. It's just that if we test SCAD patients, only about 4% will have a positive gene. So we kind of have to look at it. How we are thinking about SCAD: when we think about role of genes in blood vessel, the Marfan syndrome, that's a single gene, and that would be here. And see how 50% everybody. Typical coronary disease, there's about 300 genes associated, and it looks like SCAD's probably somewhere more like this. We've identified 17 possible genes, and so it's going to be harder for us to do that, but we're hoping to develop a polygenic risk score. So who we might think about recommending screening: those who have a family history of aneurysms, dissections, fibromuscular dysplasia, that have a clinical feature of one of those things, a man, having their SCAD less than age 40, pregnancy-associated SCAD in those who've had more than one. Some other things, these are frequently asked questions. Diet. No, there's nothing you can do, diet or supplements, that's going to make a difference with SCAD, but do eat a healthy one, because we want to prevent the development of coronary atherosclerosis or other things just generally. Remember, healthy diet and exercise reduce the risk of heart disease, cancer, and many other things. Alcohol, 1 drink per day may be safe for most. You know, we've evolved this alcohol safety, and many would say that there's no level of alcohol that is safe because of cancer risk, because of neurologic. But if you like your pint or you like your glass of wine with dinner, but do talk to your doctor if you're on medications, because sometimes alcohol can interact. Caffeine in moderation. We talked about SCAD risk and managing menopause. There's a lot more science about that hormone therapy might be beneficial, and we don't have evidence that hormone therapy is not safe in SCAD. It's just we absolutely know that sex and gender and hormones, because of pregnancy, are somehow related. And if we can keep things simple and avoid it if possible, if symptoms are manageable, and there are more medications now that are available. So our goal is to increase and disseminate knowledge about SCAD by conducting research from registries, presenting it to peers, publishing it in peers, networking, engaging our trainees. We're building the future research workforce right now. We've got a medical student who's just a rock star on a roll. She's had 2 publications and 3 posters already, and she's a second-year medical student on SCAD. We must collaborate with others and fill the knowledge gaps. And we have over 80 publications since our first one in 2012. So just a little bit about our registry. I know you've got a registry there. So now we have over 1,800 individuals. We look at the angiograms, we provide questionnaires, and then we have some follow-up. And then we see about 300 new patients in SCAD clinic every year here at Mayo, which allows us then to do things related to the imaging or the echo or other things. We're looking at a number of things. Can the angiogram tell us anything? Can the echo tell us anything? With a focus on hormones and arrhythmias, we've got a lot of sub-studies going on. This is the primary study that Dr. Tweet has gotten NIH funding for, which is looking at sort of neurovascular responses. Remember, we talked about emotional or physical stress. So are SCAD patients, do they have, are they hyperreactors? Is that one of the things that might trigger? And that's one of the hypotheses, and we'll be seeing some science coming out of that pretty soon. So as I wrap up and begin to take questions, there are a lot of resources. You've got a great resource there in Ireland, but the World Wide Web is available to everyone. And so certainly feel free to use any of these resources